Hello and welcome back to CCRN Review, Neurological Part 2. Let's keep moving. In the next section here, we're going to first talk about muscular dystrophy. So that is another one of our issues that the AACN wants us to know about for our CCRN. In order to find muscular dystrophy, there's a number of different tests that can be done. We can look at CK levels, okay, because muscular dystrophy is the situation where we start breaking down muscle over time. We can look at an ECG, a Holter monitor, echo, muscle biopsies. So there's a number of different tests we can do to find muscular dystrophy. However, when are we going to be looking for it? Well, it's got a variable course. So there may not be symptoms right away that we are noticing about our patient with muscular dystrophy. We have to be concerned about conduction system defects with our patient who's in the ICU, and the possibility that the patient may need oxygen or ventilatory support. Cerebral palsy is another neurologic condition that we have to be aware of. Number of different reasons for cerebral palsy. Okay, cerebral palsy results in dystonia, hyperreflexia, and spasticity. Symptom-wise, we see muscle rigidity, which may be asymmetrical, so we may have more on one side than the other, hyperreflexia, and hypertonia as well. Delay in their motor skills, seizures, and the defect is not progressive. Physical therapy, occupational therapy, we may have to use orthotics, casting, etc. There's a number of different medications that may be helpful. Baclofen, which is a muscle relaxer, botulinum toxin A may be helpful as well. Surgical treatments may be necessary as well to increase the joint mobility. So after a while, joints start to become locked in position because of the spasticity and because of the hypertonia. Guillain-Barre syndrome, this is a situation where we see a lot of them in the ICU. And this is a patient who has muscle weakness, and it progresses up from the legs and moves upward. Usually symmetrically upward, and it can reach the respiratory muscles, causing respiratory muscle weakness, and then the patient has to be intubated and ventilated. At the same time, when we start moving up through the thoracic and the rib cage, we start to get some autonomic instability. So we have to be careful in watching the patient's hemodynamics. Guillain-Barre syndrome, so what you're seeing over here on the right-hand side in the picture, it's a healthy nerve, and then we're seeing one that has been demyelinated over here on the right at the bottom. That's the affected nerve, so you see the exposed nerve fiber. That part of the nerve fiber is not supposed to be exposed. So what happens is that those impulses going down that nerve are either affected by other impulses, or they are scattered to other places where they're not supposed to be. So it's kind of like having frayed electrical wires, and you end up having a lot of shorts because those electrical wires are frayed. Diagnostically, it can be diagnosed by doing a lumbar puncture, nerve conduction tests. Airway management would be important, ventilatory support, pain control, okay, because the demyelination is painful, and the immune globulin may help to control the inflammation. Myasthenia gravis is an autoimmune disease. This affects primarily the acetylcholine receptors. It's chronic. Some of the hallmark symptoms are muscle weakness that gets worse with exercise and improved by rest. Okay, well, probably all of us have that to some extent, but this is one that is profound muscle weakness. Diagnostically, blood draw for acetylcholine receptor antibodies, EMGs, are also helpful. We may need to be intubated and mechanically ventilated during an acute phase. Immune globulin supportive care during the acute phase, and immune suppression and anticholinerginase medications are going to be used in the long-term setting. Aneurysms can be classified as being small, medium, large, giant, or supergiant. Kind of wonder why they came up with that classification scale. You know, somebody started measuring them, and then they found bigger ones and bigger ones. That they came up with giant and supergiant. Anyway, so we have classifications of different size of aneurysm. You know, large aneurysms typically are seen as being really bad scenarios, and the giant, supergiant type aneurysm. Those are huge aneurysms. But even the small aneurysm is a weak spot on the vessel and it can burst. So even though it's small, medium, those are still weak spots on a blood vessel and they can burst. Most of them are asymptomatic. Unfortunately, what happens is that this aneurysm has formed and it just sits there and it's asymptomatic. Nobody even knows that they have it. And then suddenly one day it pops and now we've got a subarachnoid hemorrhage. Symptom-wise, the most common symptom we're going to see is a gradual decrease in level of consciousness, but we may see some of these other things as well. We're bleeding into either the subarachnoid, which is most common, or intracerebral space. The symptoms, and explosive headache. So this is kind of the cardinal diagnostic criteria. When we think of an aneurysm bursting, we think of this explosive headache, right? Well, even though that is pretty characteristic of an aneurysm, it is not what happens in most aneurysms. So you're going to find that in most aneurysms, we just have a gradual decrease in level of consciousness. But some aneurysms will have that explosive headache, and they'll complain of that. So certainly, if somebody comes in and they say, I had this sudden explosive headache, felt like my head was exploding, I got to think aneurysm, all right? But in a lot of cases, that's not the presentation. Hunt-Hess classifications of aneurysms include grade 1 is asymptomatic, and again, remember, most of these are asymptomatic until they get to the point where they burst or we do some scan for something else and happen to find them. 2 is mild cranial nerve dysfunction. 3 is mild focal deficits, maybe some lethargy or confusion. You see, we're starting to get that decrease in level of consciousness. Grade 4, now we have a decrease in level of consciousness, hemiparesis, abnormal posturing. Grade 5, we have deep coma and posturing. So diagnostically, we're going to use that CT scan and take a look, see if we can find that aneurysm there. Can detect a lot of subarachnoid hemorrhages. CTA is pretty good, sensitivity, specificity-wise. Our angiography is the gold standard. Shoot some dye up in there and take a look. MRI, really not helpful in the first 24 hours. Treatment, okay, and in some cases, we're just going to watch it. So the aneurysm happens to be small, so we'll just watch it. But in a lot of cases, it's going to be surgical. So we have to go in there and we have to do something with it. We have to clip it and we have to take it out. They have to do something with that. They can't just leave it sitting there. So in many cases, it's going to be clipping it now or coiling the aneurysm. When we take a look at this picture over here on the right side, you can see that there's a number of different types or spots that aneurysms can form. One of the common places, and you notice here it says by incidence on the left side, and it has that kind of bar chart. So the red areas are areas where we have the higher incidence. Notice where those are. Those are all down there in a circle of Willis. The reason for that is because look at all the bifurcations. Every time there's a bifurcation in the vasculature, it makes for another weak spot. So all of these bifurcations are weak spots on the vasculature, and that's where those aneurysms form. So when you look at all of the colored spots on this diagram here, you'll notice that almost all of them are in bifurcations. Post-op care, we're going to have our fluid volume control, so we got to be careful about how much fluid we give to these patients. We don't want to create cerebral edema. Hypervolemia, which is going to be generated by normal saline and albumin, keeping the patient hypertensive and hemodiluted. So let's talk about what this means. The Triple H therapy, what we want to do is we want to have enough pressure up in the vasculature that it's going to continue to perfuse the brain. So we want to have enough pressure up there so that we're going to continue to perfuse the brain, assuming that this patient's already had this aneurysm burst and there's either some blood up there or there's some additional pressure from swelling. So we want to make sure there's enough pressure in the vasculature to create perfusion. So we'll have to have the patient hypervolemic, We don't want them to be hypovolemic. Now, that doesn't mean we're going to dump in like 30 liters of saline, right? This just means that we don't want our patient dry. Hypertensive, we want the blood pressure up there a little bit. Give a little bit of fluid. We may have to give a little bit of pressure even to keep the blood pressure up. We're talking more in the range of like 150/80, rather than maybe the patient having a blood pressure of 110/60. Hemodiluted. Okay, so we don't want this blood to be real thick when it's going through the cerebral vasculature. We want it to be able to move through there pretty quickly and pretty easily. That's why we're giving normal saline or albumin, in order to kind of increase the volume and to hemodilute the patient a little bit so that blood will flow past that area a little bit easier. AV malformation. So this is showing what an AV malformation might look like here. And so what it is just a vasculature. So the arterial and the venous vasculature have come together, and they haven't come together very neatly. So it's just kind of a clump of these little arteries and vessels, as you see here. So the veins and arteries have just kind of all grown in a very haphazard and disorganized pattern. Because of that, and they're not where they're supposed to be and functioning the way they're supposed to be, these can tend to be more fragile than the normal vasculature. So AV malformations would be a problem in that they could burst. And then we have a bleed in the patient's brain as well, depending upon where that vessel is, probably in most cases going to be subarachnoid. Symptom-wise, we're going to have intracerebral bleeding, seizures, headache, maybe recurrent migraine type of headache, progressive neurologic deficits. Okay, again, remember that even if this thing doesn't burst, we have all of this vasculature in an area that it's not supposed to be. It could be putting pressure on the brain. It could be pulling fluid and blood away from the brain tissue itself and feeding this little clump of vessels instead. So it's going to cause a variety of different problems for the patient, but the symptoms might present in a variety of ways. Some might be very subtle, some might be a little bit more obvious, like seizures. Treatment is going to be surgery. So again, here is the AV malformation on the right. So the abnormal connection there of the blood vessels. We want to correct that, and we want to move it back to looking more like a normal blood vessel would. So surgery, embolization, in many cases, what they could do is just take a catheter up there and shoot something into that abnormal connection. So on the right-hand side, shoot something into that AVM and clot it off. Radiosurgery, so we can, try and seal it shut, or just conservative medical management. Maybe giving some vasodilators to open up the rest of the vessels, and in some cases that may be helpful. Stroke is a series of situations that's very much like our acute coronary syndrome, and that's why in many cases you learn about stroke and acute coronary syndrome together, because it's a very similar type of situation that occurs in the body. In acute coronary syndrome, we have ischemia, injury, and infarct. Same thing happens with a stroke. When we don't have enough blood going to the brain, we can have ischemia. If ischemia lasts long enough and is profound enough, we can have injury. And if that is profound enough and lasts long enough and isn't recovered, we can end up with necrosis. TIAs are vascular events. So this is a ischemic event. So the same way as a patient who's having unstable angina. So a TIA, they're having an ischemic event, but for some reason, the symptoms resolve. So let's take a look at some of the ideas, some of the thought process behind how TIAs resolve. For years, we were always taught TIAs resolve because that area gets reperfused. So it's ischemic, the blood vessel kind of opens up again. It was just kind of in a little spasm, and it wakes up again and opens up, and now we have good blood flow and everything's great, right? Well, research has shown that what is occurring at the brain level could actually be permanent damage to a part of the brain during a TIA. So the damage is permanent, but the symptoms resolve because other parts of the brain take over the function for the part that's been injured. So it's kind of like we just shifted gears here. This part is injured over here, and so we moved over to this other part of the brain, and now have that part of the brain taking on that function. Look for a history of cardiac or other atherosclerotic plaques in your patient, arterial obstruction, inflammation, hematologic abnormalities. Those all may be precursors. Ischemic stroke, so we talked about some types of hemorrhagic stroke and some bleeds, but ischemic stroke is often associated with hypertension, cardiac disease, hyperlipidemia. So the same process that's occurring that caused the patient to have an MI is causing the patient to have a stroke. So you take a look at that atherosclerotic vessel there on the left, and you see it's narrowed. So if this is a narrowed vessel in the brain, eventually it could be narrowed enough that now a section of the brain is not getting enough oxygen. Okay, it doesn't have to be no oxygen. It could be just not enough. And that could cause the patient to have a TIA. Now, if we further occlude that vessel to get to the point where we're not perfusing at all, we're going to end up having a stroke. So again, like unstable angina, myocardial infarction, TIA and stroke is the same continuum, same process underlying both, just different parts of the body. Thrombotic type strokes. Okay, so we have a atherosclerotic vessel here that is forming a thrombus over a period of time. Again, we may see a TIA before this because we have a narrowed vessel, and that narrowed vessel just might not be enough blood flow to that area, and the patient has some neurologic deficit that resolves, but then later on, that vessel continues to narrow and now becomes atherosclerotic, and it's completely closed, and now we don't have perfusion to that part of the brain. Embolic strokes account for about 20% of our strokes, so 80% of them are ischemic in nature, and only 20% are going to be embolic. Carotids, cardiac origin, so those are another couple possibilities as to where this embolus come from. So in most cases, it's going to be the cardiac, it's going to be from the heart. So when we talk about embolic strokes, and you think about the patient blowing a clot, throwing a clot to the brain, sometimes we think about those venous thromboemboli. Okay, but remember, venous thromboemboli are coming back through the venous system, so they're going to get stuck in the lung. The left side of the heart is feeding the brain. So that's where these clots have to come from. So let's look for the patients who are at risk for developing clots in the heart. That would be those patients who have atrial fibrillation and other dysrhythmias, patients who have clotting disorders, etc. So here's the thrombus. It's sitting in the left atria. The patient's got atrial fibrillation, and that clot breaks off. It goes up through the central circulation, common carotid artery, and goes up to the brain and causes the patient to have a stroke. Seizures are another neurologic disorder. Seizures may be a symptom, and they can be a primary underlying problem too. As a symptom, seizures may be caused by some other neurologic disorder that's occurring. Bleeding, infection, ischemia, electrolyte disorders. In addition to an etiology, there are also precipitating factors. Not all patients who have a cerebral bleed will have a seizure. Not all patients who have a stroke will have a seizure. However, we add some of these precipitating factors like stress, sleep deprivation, fever, alcohol, or drug withdrawal. Now, when you look at the list of precipitating factors, doesn't that cover like every patient in your ICU, right? Stress, sleep deprivation, maybe fever. Okay, so those are precipitating factors on top of the underlying etiology, and that would be a patient who's more likely then to have a seizure. Types, we have the partial, the complex partial, and then the generalized seizure. Write what you see. Okay, so don't try and figure out oh, geez, which kind is this? So you can tell the physician, well, she had a complex partial. Okay, instead, just write what you see. The phases: aura, sensory or motor, and then there's a postictal phase in many cases. The aura is common with focal seizures. It can be visual, auditory, unpleasant smells or tastes, sudden strong emotion. We had a patient who was telling us that they thought something was burning. It smelled like an electrical burn, like something was burning an electrical wire. And she had that right before her seizure. So that was her aura, was this unpleasant smell. The postictal phase, what happens in this phase is that the patient has had all of this random chaotic electrical activity in the brain. And because of that, they've used up the glucose in the brain, and now they're at this point of just being tired. So in the postictal phase, the patient is often very somnolent, and the respiratory rate may even go down considerably because we've used up all the glucose in the brain. So we really have to be concerned at this point that the patient is able to continue to maintain their respirations, maintain their cardiac function. So we do want to do vital signs on this patient, keep a little eye on the patient, and make sure they're able to continue to do those things because they've used up a lot of the glucose in the brain and they're no longer able to maintain a conscious function in their body. So precautions is keep the bed low and locked, pad side rails, airway, oxygen, suction at the bedside so that we're ready if the patient does have a seizure, another seizure. Management of the seizure itself, just protect the patient from injury. We don't need to try. I've seen people that are, basically laying on the patient, trying to keep them from moving. Okay, what that's going to do is just hurt you and them. So if we're trying to restrict their movement, they're probably going to become injured, and you may become injured in the process. So we just want to keep the patient from hurting themselves. We don't want them banging their head on the side rail or something like that. But other than that, we don't want to restrict their motion too much. Maintain their airway. Document. How long did this last? When did it start? How long did it last? And what exactly did it look like? What was happening? Now, just because you see one leg moving doesn't mean the other one is. So do your assessment while you're waiting for the seizure to stop. There's nothing you can do to make it stop. You're sitting there at the bedside, you're waiting for somebody to bring the Valium or to bring the Ativan. There's nothing you can do other than that. So do an assessment. Feel both legs, feel both arms. Is it symmetrical? Doesn't have to be. And then you're going to document that so that we can tell the neurologist this is exactly what was involved. That really helps a lot with localizing the seizure and finding a good medication that's going to help to control them. Postictal care, neuro checks. Support the airway and breathing, monitor the EKG, and assess for the cause. So this is a picture here of the skull, and we have a few different kinds of objects that are in the skull here. So first of all, let's start with the big green one in the middle there, the tumor. And what this is trying to illustrate is it's trying to illustrate what happens when we have some kind of an object in the skull and how it's going to make everything shift for herniation. In other parts of your body, you have room for swelling. But we don't have any extra room up there in the brain, although in some people it might seem like there is. But in this case here, if we were to add something like a tumor, if we were to add something like a bleed, what's going to happen is that everything is going to have to shift. It's going to have to move. Now, in this example here, you can see that, first of all, in the middle, right next to that green object on the left, there's a couple little things that kind of look like maybe squiggly lines or something. That's supposed to be the ventricles. The ventricles on the affected side are completely collapsed, and the ones on the non-affected side are getting there. So if we're collapsing the ventricles, that means we're decreasing our flow of CSF. That's not going to be a good thing. The other thing that's happening is if you look up toward the top there, you can see that blue marker up there, that blue piece. And that blue piece is showing how we are moving the brain tissue over that little bony prominence there. There's a little bony prominence at the top of the skull that helps to hold the brain in place so the brain isn't sloshing back and forth. Well, here what's happening is we're pushing the brain over top of it. So there can be injury there. Down at the bottom, we can be pushing the brain down into the brainstem. Okay, so when we have a tumor or we have swelling or bleed or anything else inside the skull, that increased intracranial pressure is not just increasing pressure on the brain. It's also moving the brain in places it's not supposed to be, which causes additional damage. We have local signs that are on the area where the initial injury is, followed by central signs as we start to involve the entire brain. If we want to know about increased intracranial pressure, we're going to be looking for Cushing's triad. Cushing's triad says we'll have an increase in our systolic pressure, decrease in heart rate, and decrease in respiratory rate. Now, this occurs because the brain is not being perfused, so the sympathetic nervous system says, hey, increase our blood pressure. All right, so the blood pressure goes up, but, the sympathetic nervous system also increases heart rate. So then the rest of the body's saying, hey, we don't need all this heart rate and blood pressure. Turn this off. And it's stimulating parasympathetic activity. So what we end up with is a high systolic, low or normal diastolic, decreased heart rate, and decreased respiratory rate. That's Cushing's triad of risk factors. These are the things that tell us that our patient has increased intracranial pressure. Now, when Cushing's triad starts to resolve, that is not necessarily a good thing. It could mean that your patient is beginning to crash. Well, thank you for joining me for Neurologic Part 2. You're doing great. Let's keep moving. Let's wrap up our neuro in Part 3.